Science and Department of Informatics. So my research, as you can imagine, is in biomedical and health informatics. So today I'm going to talk about what this particular field is and what are the things that people are concerned about. So here's a very brief agenda. So first, I'm going to talk about the opportunities and challenges related to health informatics or biomedical and health informatics. If you expand the scope to include everything, and I'll go over with a very brief overview of the particular domain, and then I'll talk about three different research trends that are more recent. So meaning that people are start to explore some new directions. These are clinician burnout, which I'll go into detail later, and also to talk about automatic speech-based clinical documentation, which is a very cool trend as well. And then I'll talk about natural language processing and as well as natural language understanding. And then I'll give you some resources just in case you may be interested in this domain. You may want to engage in some future research related to biomedical and health informatics, or you may want to get into a graduate school at some point in this particular domain. So first, I'll just start with some general overview of the healthcare system, and in particular the U.S. healthcare system. So I think many of you are still young and you probably don't have a lot of experience with the hospitals and clinics, which is a great thing because it's not actually a very good, so the US healthcare system is not in a very good spot in terms of providing high quality, low cost, and accessible care. As you see in this cartoon, so basically it's a lot of issues regarding the lack of access because of the lack of insurance for a lot of people, and also because of the high cost. So many medical bills are just impossible to be afforded, and that's many in the U.S. Many families, they are bankrupted because of the medical bills that they cannot pay. So the problem is not only in terms of the absolute cost, but also in terms of the percentage of the GDP that is spent on healthcare. So as you can see, this is comparison between OECD countries. Basically, those are industrialized, developed countries. And US is clearly an outlier in terms of the proportion of healthcare expenditures of the GDP. So 2 years ago, that's the most recent data we have, 2018. It's about 17% of the entire US GDP is spent in healthcare. And that is much larger as comparing to other countries, Switzerland, Germany, France, Sweden, and so forth. So again, it's a clearly outlier. So US is putting a significant amount of more proportion of its GDP in healthcare. And the quality, so even though we spend a lot of money, the quality of care that patients in the US, they receive is not necessarily the best. So this is a study published a couple of years ago, basically comparing care across different countries. So as you can see that per capita spending, again, the US is top one. It's about almost 4 times comparing to many other countries. But in terms of the ranking of quality of care, like coordination, patient-centered care, and then in terms of access, efficiency, equity, and almost all across all dimensions, US is ranked bottom compared to other countries, even though we spend much more money than the other countries. So this is a study published in New England Journal of Medicine. Again, it shows that the US healthcare system is not delivering best care. So as you can see that the percentage of recommended care received, it's about 0.5%. So basically, if you go to the hospital or clinic, the chance that you will receive recommended care is half and half. So basically, a lot of people, they are not really receiving recommended care. They get some care, but it's not necessarily to the best known standard. And the efficiency is another issue. So I don't know if you have been to the ED in the US. I think average waiting time is probably 2-3 hours. So you basically sit there without anybody seeing you, and for a couple of hours before you can actually see a doctor. And primary care physicians, specialists, always also have a long queue. You want to, in some settings, if you want to schedule an appointment with your primary care physician, it can be 2-3 months. And even though we are spending a large amount of money, as you see, in terms of low efficiency, we are wasting a lot of money as well. 40% of diagnostic laboratory tests performed in the US were unnecessary. So basically, we spent a lot of resources in doing redundant tests, which are not actually medically necessary. And one reason is because of the legal system, the lawsuits that the healthcare system, the doctors, physicians, and hospitals, they want to be protective. Therefore, they would rather order as many tests as possible to be on the defensive side, rather than make a diagnosis based on relatively limited information. And that is one reason accounting for the high costs and also redundant, unnecessary spending. So this is a paper that was published earlier this year. They basically laid out some of the major issues in terms of the healthcare expenditure. So we know that we're spending a huge amount of money, but 30% or 34% is actually going to the administrative costs. So those are insurance companies. So anything that is not directly patient care related. So you pay for your medication, pay for your medical procedures. On top of that, you're also paying about 34% of your premium, insurance premium or out-of-pocket payments. They are going to administrative processes. So they are not going to the patient care processes. As comparing to Canada in this case, it's only 17% in Canada that is spent on administrative processes. So it's $551 per capita, and in the US, it's about $24,000. So as you see, we are spending a huge amount of money, but the money is not well used. So a large proportion of the money goes into the administrative processes. And in terms of medical errors, so even though we are the US, you may think that we have the best healthcare system in the world. But in fact, the avoidable medical mistakes is huge. So this is a paper, a landmark paper report published 1997, but the data is probably still very true today. So basically what they found by the Institute of Medicine is that preventable medical errors in the US killed 44,000 people to 98,000 people. So what that means, if you put into that in contrast, so what that means is medical errors, preventable medical errors, they killed more people than car accidents. So which is 43,000. So now you can see that this is a huge deal. So we have more people died because of preventable medical incidences than car accidents. And of course, that comes with a huge amount of cost as well, allowing healthcare costs, but also liability insurance, medical legal fees, and so forth. So it's a huge waste of resources. And that's why we are now talking about informatics, how we can use information technology in healthcare to really help deal with those crises. And the idea is that increase the availability of information will help clinicians make more informed decisions. So we can, for instance, provide computerized decision support that will catch preventable medical errors, that will recommend better standard care to patients, that will also reduce the physician, nurses, their mental processing to make their job easier. And also improving continuity of care. So a lot of medical errors happens during the handoff process. So basically, physician A hands off a patient to physician B, but physician B is not aware of all conditions of the patient, and then subsequently maybe prescribed a medication which is lethal to this patient because of allergy or some other drug interactions. So, and also one major issues occurred to accounting for poor quality of care as well as medical errors is the transition of care. So if you are discharged from the hospital, and a lot of times you return to the hospital because of the poor care, that the lack of coordination of care when you are discharged. So information technology make information flow more freely, like the hospital to primary care to specialists. So they all have full access to the patient's information. Then they would be able to make more informed decisions. And that is what the healthcare information exchange network is about. So basically, we are really trying very hard to make sure that the patient's data can be shared across hospitals, across clinics, and also between healthcare facilities and long-term care facilities like nursing homes. And the last one is improving clinical productivity, again, to solve the overcrowdedness issue in the ED, and also to reduce the demand for high-scaled healthcare workers. We need information technology to automate some processes as much as possible, so we can take care of more patients with less resources. So again, in summary, what we want to introduce informatics or biomedical and health informatics into the healthcare domain is to produce high quality, easy to use information systems that can improve quality of care, that can reduce medical errors, that can improve efficiency, and that can reduce costs. So in the US, you may think that we are far advanced in terms of using electronic medical records or other type of information systems in healthcare. So that is probably the case now, but that was not the case 15 years ago. So in the US, as of 2008, so that is 12 years ago, so very few, you may be surprised, 2008, very few hospitals and clinics that are using computerized systems to manage patient data. So as you say, 17% of outpatient practices use some sort of electronic health records in 2007, and 1.5% of the US hospitals had full-fledged medical records, electronic medical records as of 2008. And one thing that has changed significantly during that period, during this past 12 years of time, is the introduction of the HITECH Act, as part of the stimulus bill in 2009. So basically the idea is the federal government, they decided that the US healthcare system could not continue to go on this trajectory of rising cost, lower quality of care, poor coordination of care. And one solution the government they thought is we need to invest in health information technology. So what they decided to do is to put about $22 billion into health information technology. That includes about $20 billion to incentivize physicians and hospitals to adopt EHR. The EHR is Electronic Health Records System. And what it means is, so this is a recent policy. Again, the government decides to put in money and to make sure everybody, all hospitals and clinics, they adopt electronic health records. And they spend the money as incentive payments, which is kind of a very interesting model if you think about it. So they basically said that if you are, this is, again, the policy was 2009. So if you were able to demonstrate use of electronic medical records in a meaningful manner, then each physician will receive $44,000 as a payment, as a check from the federal government. And if you're if you are able to demonstrate that in 2012, you will still get 44,000. Then after that, the amount of incentive will decrease, and there will be also negative incentives after 2015. So after 2015, if you are still unable to demonstrate meaningful use of electronic health record system, then you may receive less payment from the government insurance programs like Medicare. So the idea is that the hospitals and clinics, they need to use a certified EHR in a meaningful manner. So and also they need to meaningful, meaning it's more interesting. If you are interested in this part of the history, I highly recommend you to just Google search for meaningful use of EHR, and you will see how meaningful is defined. It's actually not defined as quality of care, as lower rate of medical errors. It's actually defined very mechanically as how many patients you put data in an electronic format. So that's that is how this program worked. So besides meaningful use of certified EHR, you also need to demonstrate the capability of electronically exchanging information with other hospitals and clinics. And lastly, you also need to submit clinical quality measures and other type of measures, performance measures, to the CMS in terms of that you need to, the government insurance, they need to make sure that you are delivering high quality of care in order to get the proper payment from the government insurance. So that program, in terms of promoting adoption of electronic health records, has been very successful. So as you see, 2017, 80% of office-based, so the clinic-based physicians, they have adopted a certified EHR system. And for non-federal acute care hospitals, the adoption rate is was almost 100% by the year of 2017. So it has been, in the past 15 years has been a very interesting time for biomedical and health informatics, because of the policy mandate that requires really requires all hospitals and clinics to adopt the electronic health record system. And electronic health records, that is really the foundation of all other health information technology. So that's where the patient data are captured, stored, and then building upon that, you are able to do computerized decision support. You can do computerized prescription ordering system. You can do information exchange in an electronic manner across the hospitals and clinics. So that's really the foundation. So now in 2020, we can confidently say that the adoption of electronic system in healthcare to manage patient data is nearly 100% across all settings. Now the question is, so what are we now concerned about, and why do we need a domain called health informatics to really figure out what we should do? So the problem with electronic health records, there has been a long history of research suggesting this is not the silver bullet to solve all the issues we have. So even though the federal government, they thought as long as you have electronic health records, then all the quality problems, all the medical error problems, they'll be gone. So that is simply not true. So there has been a lot of research even before 2009 demonstrating that implementation of electronic health record system is not going to automatically realize those benefits. So cost is one dimension, and the quality of care, that is another dimension. So basically there's no evidence, even before 2009, again, there was no evidence that implementation of EHR is going to be associated with better quality of care. And one reason is because, again, medical records is a electronic form of the clinical documentation. So in itself, it does not directly contribute to better care. or lower medical errors, right? So it's just a media of documenting information. So now the value added piece on top of electronic medical records, health records, is the computerized decision support. So basically, you have a computer system that can process the information being entered. Then it can detect errors, prevent those medical mistakes and adverse events. It can also provide reminders to make sure a higher quality standard of care is delivered, to make sure the patients receive adequate preventive care so they don't get sick. So those kind of things are what we call computerized decision support. And in this particular case, this paper I'm showing here, that's a drug safety alert. So that's basically telling you don't prescribe this drug for this patient, otherwise you may kill the patient. So that's the kind of a drug safety alerts. But there has been a lot of studies on those kind of alerts, and the general consensus is those alerts, even though well-intended, they don't really work because most of the time, clinicians, that includes physician, nurses, pharmacists, they generally override those alerts or they just totally ignore them. So 50% to almost 100% of the case, those drug safety alerts are ignored. That is the so-called alert fatigue phenomena. So I don't know if you have ever been into an ICU environment in a hospital. So you can see that there are constant alerts popping up from the machines, from screens, flashing lights, and so forth. So if you're in a hospital environment, you're constantly exposed to alerts, and over time, then you start to ignore them. And for computerized alerts in particular, because it's so easy to program something that will pop up, and then healthcare administrators, quality officers, they tend to put in a lot of alerts, regardless how useful they are. And so then we run into the situation where we have a lot of alerts, important or less important, but because of the high volume, physicians, nurses, pharmacists, they just generally just ignore all of them. They don't have time to read and respond to those alerts. So that's kind of what we need to do in terms of health informatics to provide better designed systems that has scientific underpinning to, so we have a better understanding of human nature, the cognition, ergonomics, and how human works with computer to solve complicated problems in a mission critical environment. And this is kind of the car manufacturer example that I often give. So in order to produce a good high quality car, you need a lot of different science from different domains, from engineering to material science, to cognition, to industrial design, operation management, in order to produce high quality, low cost cars. And this is what I think the healthcare information systems, the stage is like. So basically we are the practice of electronic health records, computerized decision support, and all other health IT systems are in a stage that they look really good outside, but internally, if you talk to physicians, nurses, pharmacists, most of them will tell you that their systems do not work. They don't work with their workflow. They don't work with their mental model of providing care. And they become, the physicians, nurses, pharmacists, they become a documenting machine to basically entering data into the system. And they are taking they spend 4 hours, 5 hours entering information into the electronic system without knowing why they need to do so. So this is the status quo of the health information technology. And also we focus a lot on automation. So as you can imagine, we introduce computerized systems with the hope that we can have clinicians see more patients in a shorter period of time. So because of the design of the systems, focusing so much on automation and also focusing so much on revenue management. So how we can see a patient in a certain way in order to maximize revenue. So you can have insurance company pay you more with the computerized system constantly remind you to do things that you normally don't do. So that's another reason why the practice of health information technology has been very poor this past 15 years. So this is one example of what extreme example related to usability. So I don't know if you are some of you might from informatics background. So if you are concerned about how to design usable systems, so healthcare IT then is one application domain you should definitely study, because healthcare IT systems generally are very poorly designed. So basically, you put everything together without thinking about cognition, without thinking about the workflow, without thinking about how physicians, nurses, pharmacists, how their mental model works in consuming information or in entering information into the system. So this is a very well-known phenomenon in healthcare, is the user interface design is very poor. And people tend not to do any usability testing. And those systems, as you can imagine, we introduce poorly designed systems into healthcare that actually facilitate medical errors instead of reducing them. So, and this is not a one-off study. So there are many, many studies in health informatics demonstrated that the information systems introduced in the past 10 years, they actually cause more issues than reducing cost, than their original designed objectives in terms of reducing cost, improving quality, and reducing medical errors. So this paper was published almost 20 years ago. It shows that implementation of computerized physician order entry system, so basically that's where you enter medication orders, facilitates medication errors. So you are more likely to commit errors in medication prescription when you are using a computerized system than using a paper form. So one reason, for example, is it's much easier on a computer system to misidentify a patient. So if you search for the name or you type in the medical record number, it's much easier to make mistakes. And if you search by first name, last name, for instance, you'll bring up all patients with similar names. And then the chance of clicking a wrong one and then prescribing a medication for a wrong patient is much higher than when you are doing this on a piece of paper. So this is another study, which is also a milestone kind of study, which the title reads as unexpected increased mortality after implementation of a commercially sold computerized physician order entry system. So really the title basically says that implementation of this computerized physician order entry system kills more patients. So more patients died in the hospital because of the implementation of the system. So they basically did a before and after study, and they found with the system as intervention, significantly higher mortality rate was observed after the implementation of the system, with all other factors controlled. So again, it's a universal problem now. So from the for-profit hospitals to academic medical centers to the VA, the vulnerability introduced by IT from the poor system design or unreliable system performance, they are really contributing to a lot of issues. So that's kind of set up the stage of this particular domain. So I wanted to, that's why we need health informatics or biomedical and health informatics in order to design better systems that can overcome those known issues. So this is a formal definition. It's very long, but I'll have a shorter version of it. So health informatics or biomedical and health informatics, it's an evolving scientific discipline and really concerned about optimal use of data. And that involves, of course, connection, storage, retrieval, communication. So basically, it's about how we can optimize user information, data, information, knowledge in order to produce higher quality healthcare delivery system. And we use a lot of underlying sciences from information, social to technology. So we need to understand information technology, how healthcare information should be organized. We need to understand social science, how people and organization work, interplay with health information technologies in order to produce better results. And of course, we need to understand the technology. And it can be applied to all basic and applied areas, medical, biomedical, and health. And so this is a sort of illustrates different scientific domains within biomedical and health informatics. So there is bioinformatics, which deals primarily with genomic information, genetic information, and then there's imaging, public health, clinical. So really depending on the level of care, you can go with a basic science level, process information from biological processes, and you can go with more imaging or biomedical engineering-driven angles. You may also deal with clinical care or public health. And there are so many subdomains, subspecialties in biomedical and health informatics. So basically, that's the same number of the subdomains as how many medical specialties are there. Primary care informatics, nursing informatics, pharmaceutical informatics, you name it. So basically, you attach a particular medical specialty with informatics that becomes its own domain. And of course, as I mentioned, we have bio, we have public health. We also now have a consumer health informatics that deals with mobile apps, home-based devices, remote monitoring, telemedicine. So basically, the consumers, they are now in the driver's seat in terms of managing and controlling their home health using information technology. So there are a lot of component sciences underlying health informatics, and to name a few, computer science, human-computer interaction, computer-supported cooperative work. Then we also have computational linguistics to kind of understand the medical language, the terminology, the kind of the expression of physicians in their medical notes. So we can understand how the notes or free text information can be used, computed, and used. And of course, data mining, machine learning is one very crucial part nowadays for healthcare, with massive data connected from individuals, both in their clinical processes or in the lab, or the genomic information connected from the biospecimens, how we can mine the data to predict the disease progression, to associate certain genetic profiles with certain disease, and so forth. And then cognitive science. So as I mentioned earlier, we need to understand how physicians, nurses think, what their mental model is when they process information, and then decide what is the best to care, how to best care a patient. Information science. So how do we organize information in a cohesive, efficient manner? Decision science. So we need to understand how decisions is made, either by a medical professional or by the patient, in order to design systems that can support those decision-making processes. Industrial engineering, so we need to understand workflow. What's the optimal way of organizing healthcare, both physical layout as well as the workflow re-engineering to make sure that information systems do not stay in the way of delivering care. Instead, they will facilitate delivering of care. So with that, I want to pause for two minutes for any questions you may have of the overview. Any questions?
I had one quick question. I was curious about on the payment incentives policy. Is that only in the U.S.? Is U.S. healthcare the only one that would accommodate something like that?
Yes. U.S. is the only one that has that kind of policy, and UK, for instance, they have a national healthcare system. It's also national kind of insurance as well. So they have the mandate. They can't ask people to do X, Y, Z. In the U.S., of course, it's a free market. the government, they have some leverage. They can pay you less for Medicare, Medicaid patients, but they don't have the leverage of forcing people to do something. So in the U.S., the only way they can really do is to provide monetary incentives to convince people to adopt systems.
I see.
Yeah.
Thank you.
Yeah. US. That's only one. Any other questions?
Yeah, I wanted to put something out there to all the SURF-IoT fellows. You know, now that you've listened to Professor Zheng's presentation and, you know, some of this, you know, quite shocking information, if you will, has it crossed anyone's mind, you know, as you think about the project that you're currently involved in, how this type of health information flow from physician to nursing to, you know, and how it is shared amongst physicians as well as or controlled by patients, how that might even have an impact on your project. I know that a number of you are involved in something that is health related, and that also there's data collection involved, and you know, I think there's certain rules and also laws that need to be included in the project in terms of privacy, etc. So I was just kind of curious how this is kind of reflecting on your project. Does anybody want to jump in?
I guess I could jump in a little bit, since my project is about trying to make like a watch service, or to help work on a watch service that would be able to send like health information from patients to like physicians or healthcare officials like in real time. It makes sense that you want to make sure that it can be, you want the system to be as usable by both the patient and the administrators so that it could be actually properly used. Because if the system, if like the data input system was very convoluted, or if on the administrator side it was very hard to like parse out the actual information and the conclusions of that like the processing of that information, like then it just wouldn't be very valuable to either side. If it can't do its task unless both the patient and the administrator are able to properly interact with the system.
Mm-hmm.
Yeah. And for consumer health informatics, meaning if you are developing mobile apps, home wearable devices, so one crucial issue is whether you want to involve medical providers into the process. They want to share the data with the patient, with the person's primary care physician. And so right now it's actually very interesting in terms of as a researcher, especially researchers from engineering, computer science, they think this is a great idea. Why not we connect a large amount of data and send the data to their physicians? But if you ask your physicians, they will say, we're not interested. We are overwhelmed. I'm seeing like 30 patients a day. I have no time to really take a look at the data generated by those devices. And also we don't want to be held liable. The devices may not generate highly accurate data as compared to medical grade devices. Then if I make a decision based on information patient gathered from their mobile apps or from their wearable devices, then I may be held accountable for any kind of medical incidents that may occur as consequences. So there are a lot of issues related to that, which really makes the integration of those patient-oriented devices with the medical professionals very challenging. And that's unfortunately the reality of the U.S. healthcare system.
Thank you. You know, Marwin, Zheng, can you turn on your video? Because I know you are working with Professor Epstein on a project that is tracking women's health data. So I'm just kind of curious of how is what Professor Zheng presented today, how is that having an impact on your product, if any?
So my project doesn't really deal directly with patient data, but more with personal usage data. But learning from like basically what Professor Zheng presented, like an overview of the disciplines and all that, actually opened my eyes a lot on how like to deal with sensitive patient data, because bioinformatics is kind of one of the topics that I'm interested in. So learning a lot about how sensitive the data is and how a lot of motivation being put into like the research behind this is actually really interesting for me.
All right. Yeah, sounds good. If you're interested, we can definitely talk more. And
Yeah.
I think in terms of biomedical and health informatics, I'm probably one of the best resource on campus doing this type of work. I've been doing this for 20 years, and nobody else at UCI actually does what I do.
Sounds good.
All right, so now I'll move to the next part of the presentation. Basically, very briefly about three very recent research trends that I have been observing in biomedical and health informatics. Of course, these are not representative in terms of, these are not everything that is of the highest importance. But these tend to be something that everybody is talking about. And of course, there are a lot of basic science research, bioinformatics, that is also very exciting. But today I'm going to focus on more my perspective as a human-computer interaction researcher. So what I see as the most recent interesting trends. So the first one is clinician burnout. So this is something that we have been talking about in the past 2-3 years. It's relatively new, actually, maybe more than 2-3, maybe about 10 years. So ever since the introduction of electronic health records, so suddenly people are starting to talk about clinician burnout. So burnout, as you see, it's just like medical professionals, they felt they are burnt out because of the high demand of the work, but we didn't see this as much as today. And so then the question is, of course, what has changed? And the major change in the past 15 years is, of course, introduction of IT. So as you can see on the slide, over the past 10 years, the U.S. there is a epidemic of clinician burnout. About over 50% of physicians they reported some level of burnout, and 70% of electronic health records users they reported health IT related stress. So even though we are not definitively knowing that health IT or electronic health records in particular is causing burnout, but there appears to be a strong association with introduction of electronic systems in healthcare that apparently is associated with a much higher frequency of reporting burnout. So if you're interested in this subject, there are many papers now, many published in the past 2-3 years. And there is a special issue in the Journal of Medical Informatics American Medical Informatics Association, which is dedicated to burnout. Again, if you are in this field, this is a topic that people are constantly talking about in the past few years. And health IT, again, is believed to be a major contributing factor to clinician burnout. And the result of burnout is very severe. So not only physicians' well-being, they don't feel satisfied with their job, and they have a higher chance of making mistakes, and then they're just unhappy about being a medical professional. And there is also a higher trend of medically prepared professionals. They leave the medical field because of the burnout. They don't feel doing this any longer because they spend 4 hours, 5 hours a day entering data into the computerized system, and they are constantly required to respond to computerized alerts or other sorts of mandates. They have to do X, Y, Z because of regulations, and those are enforced through information systems. So this is one very interesting new trend that has been observed in the field of biomedical and health informatics in the past couple of years. And again, health IT is believed to be the major contributor. So the next one is speech-based clinical documentation, which is related to burnout. So one major source of burnout is the amount of time and energy that a physician needs to spend in documenting information about the patient. So then the question is, how can we use technology to facilitate clinical documentation? And I think an obvious technology is automated speech recognition. So I don't know if I can play the video.
Scribe captures doctor-patient conversations and creates medical intelligence to generate a medical note.
Just going to ask you a series of questions to make sure we're not missing.
While the doctor focuses on the patient, the system captures the dialogue.
Am I tired lately or anything like that?
I'm just a little tired
Okay.
from it.
How about any problems with, have you noticed a fever or just generally feeling unwell?
No.
Okay. You mentioned the headache.
Just
Integrating this dialogue with context from the patient's health record, a learning system in the cloud generates a medical note. After the visit, the doctor can easily edit the note generated by the system. Let's see how this technology works.
So I'll stop right there. So you get the idea. Medical professionals, they are burned out. And one major reason is the amount of time, energy for clinical documentation. So now the technology companies, from Google to Microsoft to Nuance, they all jumped in, trying to develop some sort of automated documentation system based on the conversation. So in theory, this should work pretty well, right? If you put some microphones in the exam room, they'll pick up the conversation. Then you have automatic speech recognition, turn that into text transcript, and then turn the transcript into clinical documentation. But there are, of course, a lot of challenges of how to make this work technologically, and also the privacy concerns, the compliance concerns. There are a lot of issues that need to be resolved. But this particular application, speech-based clinical documentation, that is one area that we have seen a lot of development in the past few years. As I said, Google, Microsoft, they all jumped in, trying to be a leader in medical documentation. So they capture data. The Google is interested not only in capturing internet data, but also in clinical data. So they can use clinical data to do medical research, to do large amount of the clinical data mining. And Microsoft are also interested in becoming a vendor in this space. So the last piece is natural language understanding. So this is one step further from natural language processing. So basically, the idea is that 80% of information is buried in free text notes. So even though we require clinicians to code certain information, smoking, yes, no, then blood pressure, other type of quantifiable data. But in reality, a lot of context is still written in free text. So then the question is, how do we convert free text into valuable information that can be computed and that can be used by computer systems in making decisions, in conducting research about what medication works, what does not work, and so forth. So extracting information from notes is highly desirable, and that's the field of NLP, the natural language processing, and also understanding the context, not only extracting the concepts, but also understanding for instance, causality. If you have a medication side effect, do we know for sure which medication is causing the side effect based on the notes? So those are very interesting. This is very interesting, exciting domain that has been flourishing for the past almost 10 years. There are a lot of engineering, computer science researchers are now doing natural language processing in the medical context. But as you can imagine, it's very challenging. So medical text is particularly difficult to process. And sometimes you have two physicians reading the same piece of documentation. They may not agree what is documented. So there are a lot of frequent use of acronyms, abbreviation. There's a lot of ambiguous terms, like clinicians, they constantly use those terms. Like for instance, CA, does that mean California? Does that mean cancer? So you have to actually put that into context in order to understand what those terms mean, and that is very challenging for computers in order to understand the meaning of the text based on the surrounding context. And then of course poor quality of source documentation. So NLP process text. So if the text is not well written, then it'll be a problem. But as you can imagine, physicians, they are not very good notes keepers. They often document as fast as possible so they can move on to the next patient. So the medical documentation, even though physicians spend a huge amount of time in documenting, but the overall quality is very poor. And also because of the use of electronic systems, copy-paste, redundant information, automatically generate the templates, even automatically generate data as a free text. That is also causing huge problems in terms of in medical processing, in natural language processing of the text. But this particular field is another domain where that has received a lot of attention. So I'll with only 1 minute left, so I'll fly through some of the resources. So these are professional organizations in this particular domain, from American Medical Informatics Association to the international one, and then Health Information Management Association and so forth. There are many major conferences. The American Medical Informatics Association Annual Symposium in November, that's a major conference all researchers would go. And there are many other conferences, Pervasive Health, that's about the wearable devices, mobile apps. And those are flagship journals in this particular domain. And so I'll share the slides, but if you're interested in applying for graduate school programs in health, biomedical or health informatics, then I listed a number of well-known programs and their strengths. Columbia, for instance, they have a department of biomedical informatics. They are known for their work in natural language processing. And Stanford, they are known for text mining, ontology, and taxonomy. University of Michigan, policy, usability, data mining, and Washington, consumer health informatics. If you are interested in mobile apps, wearable devices used in the healthcare context, then University of Washington program is probably the best, provides best fit. And some other resources, National Resource Center for Health IT by the Agency for Healthcare Quality, Research and Quality, AMIA website, of course, GMIA, which is a flagship journal. So those are some resources I would like to share, and maybe I can stay around for another 5 minutes to answer questions. Thank you.
Thank you very much, Professor Zheng. That was quite amazing, just the volume and just the realization that, you think you're in an advanced, industrially advanced country, and to find that, we have such a high mortality rate, and that, the impact that it has on our lives today. So I think it's quite stunning. So Anand or Vikram, did you have any questions for Dr. Zheng?
I had a quick question too. When you were talking about burnout, I'm just curious that it looked like those findings were from 2016. Do you have any thoughts about what those numbers might be with a pandemic on top of IT for burnout with healthcare? And the other question I had was, I was interested if those numbers were US numbers and if those numbers might have been compared with other countries, how they might compare.
Oh.
You're muted.
Muted, Professor Zheng.
Oh, here we go. I'm sorry. Yeah, those numbers are from the U.S. And the U.S. it's particularly problematic. So we don't really observe the same amount of burnout as reported in some European countries. Not all of them, but most of them, they don't have the same level of concern. And one reason is because in the U.S., the regulatory burden, the administrative burden. So clinicians, they document not because they need to document for patient care, but they need to document for compliance, and they need to document to justify the billing, to justify payments that they will claim from the insurance company. So they put in a lot of information that is not really clinically necessary. So that is when you see you are doing a lot of work that you don't perceive as valuable. So that is a mental kind of injury. It's a moral injury, and that is another source of burnout. So it's, if you compare U.S. physicians with European physicians, in terms of the amount of time they spend per patient, even the amount of time they spend on documentation might not be significantly different. But the U.S., because of the regulatory requirements, because of the insurance, the nature of the insurance, how insurance works, you have to document for compliance. You have to document to justify billing. And those are not what physicians want to do. And that's a major contributing source of burnout of the U.S. Medical professionals as compared to other countries.
Thanks. That's really fascinating. Thank you.
Yeah. And even within the U.S., there have been studies comparing the VA physicians with non-VA physicians. The VA is a very interesting place. That's essentially government-paid insurance program, right? You don't even need to document ICD codes sometimes. You just you deliver care, the government will pick up the charges. And there is a significantly lower level among the VA physicians in perceiving burnout as comparing to other hospitals and clinics. Again, regulatory requirements, insurance justification, those becomes really the burden of documentation. It's not that you spend a lot of time documenting patient information. You are spending a lot of time justifying why you did X, Y, Z. It's kind of a very diminishing the autonomy and the job satisfaction of providing medical care.
Right, just the bureaucracy.
Yes. It's like we have to fill out a lot of forms nowadays after the pandemic. Every piece of equipment we purchase as a faculty, I need to fill in a form why I need this piece of equipment. And we didn't do that before the pandemic. And those are kind of examples. It's a lot of paperwork, administrative paperwork that are forced upon physicians, and they don't like it. And that's why they felt burned out. And a lot of those policies are enforced through IT. So that's why people say IT is a cause of burnout, but it's not. It's just a media. It's a mediating platform that really reflects those regulatory and insurance requirements.
It's really interesting. Sounds like there's an inference almost to that the insurance industry has something to do with the burnout, or those requirements that are stipulated by the insurance industry, versus having it, comparing the U.S. to countries where the healthcare is government supplied or government run versus privately run through insurance.
Mhm.
I mean, the UK, you had mentioned Canada, and I know some European countries are, also have government-run insurance. That is probably contributing to that.
Yeah, I think pros and
Or, discrepancy between the countries and the
yeah. Yeah, I mean, pros and cons. I mean, the government-run programs also have efficiency issues, and also if it's a public goods, then people tend not to really value the service they receive. So they also have a lot of overcrowding issues. Again, because it's almost free, then obviously people may take advantage of the free services. The U.S. We are moving away from pay for volume to pay for performance, meaning that no longer physicians, they used to be paid based on patients they saw, based on the volume of services they provide. More and more, we're moving away from that. So we are paying for performance. We're paying for quality of care. Then that becomes also part of the issue is how do you document to demonstrate you delivered higher quality of care? so it's kind of a catch-22. So you want people to deliver higher quality of care, but in order to know that, you require more documentation. And then that becomes a source of burnout.
I can certainly sympathize with the physicians that need to go through every little piece of information just to justify the charges that they submit, and then ultimately that's knocked down by a good 3/4 of what they bill.
Yeah,
50%. So anyway, Melinda, Vikram, John, Ananth, Regine, did you guys have any other questions that you'd like to run by Professor Zheng?
Not a question, but I did take health policy last quarter, and Professor Zheng did go over a lot of discrepancies within the healthcare system in the United States. A lot of it is caused by human error, and I believe that something like EHR would definitely help in the sense of being able to streamline all these processes between doctors and pharmacists and all that. But I do have a question in terms of long-term outcomes. Is this going to be something that's going to be easy to implement with in mind of the current healthcare system, where there is a lot of issues with insurances, healthcare infrastructure? How will this be implemented in the long run? Will it be a whole, will all hospitals be integrated with this at a time, or what is the expectation, I guess? I don't know if that's, it's a really long question, but I guess how will the implementation be with all those considerations? And yeah, how will that be implemented at a time?
In how house IT systems are implemented over time?
Well, we're thinking also about these community hospitals, for-profits, academic hospitals. There is already a digital divide going on within the United States, which causes a lot of issues within the healthcare system. So I was wondering how this is going to be implemented with these infrastructures within communities, these technical disparities.
Well, that's one of the issues. Even the 2009 program, they recognized this issue, but they did do some very good things. They provided, they set up a lot of regional extension centers. So basically, those are resource centers across the U.S. Providing assistance in adopting electronic health record systems, especially among those vulnerable free clinics, safety net clinics. So from the medical side, there has been a lot of special assistance to underserved communities, but the digital divide in the consumer health space, I think that is more particularly concerning because of the issue of not only lack of resources or internet connection even, but more of the health literacy. So it's just, I think some of you work on tracking and other type of mobile-based information gathering for patients. But that doing any kind of tracking or any kind of interpretation of the data requires some pretty sophisticated knowledge about what you are doing, about the medical, the context of the disease, and that is causing a lot. I think that is more important than the availability of technology itself. So I don't know if that makes sense, but yeah. But my experience is teaching people, even if you give them free iPads, devices, free internet, still the adoption of those devices or the applications is very low because of the health literacy issues.
Okay, yeah, that makes, yeah, it's, my professor back in health policy did not explain it. So thank you for going over that, over this presentation. So thank you so much.
Okay. All right, sounds good. I think we're over time, but again, I'm here. So if you are interested in biomedical and health informatics, especially if you are interested in doing research or pursuing a graduate degree in this particular domain, then I would be the best person to contact. I have a lot of information about those programs, and I used to be the director of health informatics program at the University of Michigan. So I know a lot of folks for working in this particular domain. And yeah, again, just I'll be a resource that you can leverage if you're interested in this particular domain.
Excellent. Well, thank you so much, Professor. That was a really great talk. And thank you all the fellows that made the time to participate and ask questions. If you have any questions about getting in touch with Professor Zheng, you can certainly also ask me, and I'll be happy to forward information on to you. So with that said, we are a few minutes after our time. Thank you so much. Stay cool.
Okay.
And stay healthy. Bye-bye.
Bye. Thank you.
See ya.